Welcome to the Windsor-Essex County Health Unit's presentation on long-term care homes and COVID-19. Please note that the information in this presentation is current as of Wednesday, March 25th, 2020. Please visit our website for the most up-to-date information. By now, everyone probably already has some knowledge of the novel coronavirus disease COVID-19. COVID-19 is an infectious disease caused by the novel coronavirus SARS-CoV-2. Coronaviruses are a large family of viruses, some of which only infect animals and some only humans. Currently, there are 7 strains of coronaviruses that are able to cause illnesses in humans. Some may only cause minor respiratory symptoms similar to those of a cold, but have also been associated with more serious and life-threatening diseases such as SARS-CoV or MERS-CoV. The strain of coronavirus found in Wuhan, China at the end of December 2019 is the most recent of 7 known strains. This new strain has never been previously identified in humans, meaning no one has immunity. So the best way to avoid being sick is avoid being exposed. The virus is spread from person to person through respiratory droplets, such as saliva or mucus, when an infected individual coughs or sneezes. Because this virus is able to survive on surface for a long period of time, it can also be spread from touching contaminated surfaces and then touching eyes, nose, or mouth before washing hands. It can take as little as 2 days and as many as 14 days after being exposed for the first symptoms to develop. For most people, symptoms typically develop around day 5 to 6. Common symptoms include fever, tiredness, dry cough, shortness of breath, pneumonia, and in severe cases, death. Very few people will also report diarrhea, nausea, or runny nose. To date, there is no vaccine and no specific medical treatment to prevent or treat COVID-19. Next, we will talk about infection prevention and control practices pertaining to the COVID-19 outbreak. Emerging information on COVID-19 suggests that elderly and those with underlying health conditions are at increased risk of severe outcomes. Infection prevention and control practices. Implementing infection prevention and control practices plays a significant role in controlling the spread of any communicable diseases, including COVID-19, in any healthcare setting. Infection prevention and control practices involve properly monitoring staff and residents for symptoms of acute respiratory infections, properly notifying the Windsor-Essex County Health Unit for suspected outbreaks of respiratory illness, including COVID-19, collecting acute respiratory specimens for testing, using appropriate personal protective equipment, controlling the movement of residents and staff, implementing active screening for visitors, implementing proper cleaning and disinfection practices, and lastly, being prepared with a response plan. All long-term care facilities must continue to conduct ongoing surveillance and monitoring for acute respiratory symptoms. Surveillance should be conducted for both staff and residents to ensure early identification of symptoms. Continue to track and document staff and residents with respiratory or enteric symptoms on line lists. All suspect respiratory and enteric outbreaks are still required to be reported to the health unit via telephone or fax. A suspect respiratory outbreak is defined as 2 cases of acute respiratory infection occurring within 48 hours with any common epidemiological link, or 1 laboratory-confirmed case of influenza. COVID-19 is designated as a disease of public health significance and therefore reportable under the Health Protection and Promotion Act. All suspected and confirmed cases of COVID-19 must be reported to the health unit immediately. This includes staff or residents that had possible exposures to a suspected or confirmed case of COVID-19. The WECHU will begin contact tracing and will follow up with facilities regarding staff and residents in isolation. Any COVID-19 related questions are to be directed to the Infectious Disease Prevention Department at 519-258-2146, extension 1420. The case definition of COVID-19 has been updated by the Ministry of Health and is current as of March 13, 2020. Case definitions change over time, so please continue checking with the Ministry for the most up-to-date information. These case definitions should be used for surveillance purposes only. A probable case is someone with a fever over 38 degrees Celsius and/or onset or exacerbation of chronic cough and any of the following within 14 days prior to onset of illness. Travel to an impacted area or close contact with a confirmed or probable case of COVID-19 or close contact with a person with acute respiratory illness who has been to an impacted area. Confirmed cases include anyone with laboratory confirmation of COVID-19 testing using a validated assay. Part of controlling the spread of disease is being able to identify the causative agent. Specimen collection in general for long-term care homes has not changed in practice. Facilities are to continue swabbing for residents who have symptoms of acute respiratory infection. Nasopharyngeal swabs should be taken from residents who most recently became ill within 48 hours of onset of symptoms. The nasopharyngeal swabs collected for acute respiratory illness or outbreaks will automatically be tested for all respiratory diseases, including COVID-19. When collecting NP swab specimens, general PPE such as gloves, gowns, procedure mask, and eye protection is required. An N95 respirator is not required during NP specimen collection, as it is a non-aerosol generating medical procedure. Next, we will discuss personal protective equipment regarding COVID-19. Personal protective equipment. Healthcare workers providing care to any residents with acute respiratory symptoms should follow additional precautions. When providing care for residents who are suspect or confirmed COVID-19, they must follow droplet and contact precautions. This includes wearing a mask and eye protection within 2 meters of the resident, wearing gloves and a long-sleeve gown for direct care. If a resident ever needs to leave their room, they must wear a mask if tolerated, and try to dedicate specific equipment to a resident if possible, or make sure to disinfect before use with another resident. Facilities should ensure signage is posted on doors of ill residents' rooms to remind staff to practice droplet and contact precautions. For healthcare workers providing direct care to suspected or confirmed residents, including performing nasopharyngeal or oropharyngeal swab collections, droplet and contact precautions must be followed. A surgical procedure mask is sufficient in providing protection for healthcare workers providing direct care. Direct care includes providing hands-on care such as bathing, washing, turning the resident, changing clothing, continence care, dressing changes, care of open wounds, lesions, or toileting. Feeding and pushing a wheelchair are not classified as direct care. However, for healthcare workers providing CPAP and/or opening suctioning or performing any aerosol-generating procedures, an N95 respirator mask must be worn. Ensure all staff on-site are N95 mask fitted. Discard masks after a single use. In addition, when a resident is placed on droplet and contact precautions, gloves, isolation gowns, and eye protection must be used when providing direct care. Facilities should ensure personal protective equipment are readily available outside the residents' rooms for use by healthcare workers and visitors prior to entering the resident's room. If an environmental service worker is entering the room of a resident suspected or confirmed with COVID-19, droplet and contact precautions must be followed. Keep in mind, PPE is not required for performing administrative tasks that do not involve contact with suspect or confirmed cases. Personal protective equipment is a key element in preventing the transmission of disease. Personal protective equipment must be used properly and safely removed to prevent contamination of clothing, skin, or mucous membranes and contribute to further spread of disease. Wearing gloves is not a substitute for hand hygiene. Staff must perform hand hygiene prior to putting on and after taking off gloves. All staff should review proper donning and doffing procedures and ensure personal protective equipment are disposed of in proper waste containers after use. Waste containers should be provided in residents' rooms for the disposal of soiled personal protective equipment. If an N95 respirator is worn, remove all personal protective equipment before exiting the patient room. Remove the N95 respirator after leaving the resident's room and closing the door. Staff must perform hand hygiene as per routine practices. Hand hygiene must be performed before and after each resident contact, before performing invasive procedures, before putting on and after taking off gloves or other PPE, after care involving bodily fluids, whenever there is a doubt. Ensure alcohol-based hand rub, ABHR, is available at entrances and exits of facility, residential units, and point of care in the residents' rooms. In addition to hand hygiene, all individuals should be advised to practice respiratory etiquette when coughing or sneezing. Turn head away from others, cover the nose and mouth with tissue or sneeze into your sleeve, discard tissues immediately after use into garbage, perform hand hygiene immediately after disposal of tissue. Resident and staff movement. Residents who are not living in a single room should maintain a separation of at least 2 meters between the residents in the room with privacy curtains drawn. Doors may remain open. If a facility is under suspected or confirmed respiratory or enteric outbreak, outbreak measures should be immediately put into place. For example, isolate symptomatic residents, canceling non-essential activities, and using tray service. Facilities should be aware that on March 24, 2020, the Chief Medical Officer of Health issued a new directive to prevent residents from leaving the home for short-stay absences to visit family and friends. In addition, residents who wish to go outside of the home can remain on the property and maintain social distancing, 2 meters apart. This will ensure that the residents do not inadvertently contract COVID-19 while out of the home and spread the virus upon their return. If residents are severely ill and require hospitalization, make sure the hospital and ambulatory services are notified of the transfer and notify these services if the resident is a case of a suspected or confirmed respiratory outbreak or if the resident is suspected or confirmed to have COVID-19. It is recommended that patient transfer services are not to be used for a resident who is suspected or confirmed to have COVID-19. Staff movement should be minimized between affected and unaffected areas during an outbreak. Staff should be cohorted if possible by assigning some staff to care for ill residents and others to care for the well residents. Facilities should be aware that on March 22, 2020, the Ministry of Health and Long-Term Care issued a new directive recommending to limit the number of work locations that employees are working at wherever possible. Employers should work with employees to ensure a staffing plan is in place to address concerns with adequate staff to patient ratios as workloads increase. Active screening. Active screening means screening all individuals for signs and symptoms of acute respiratory infections before entering a facility that is in a suspected or confirmed respiratory outbreak. A COVID-19 directive was issued by the Ministry of Health and Long-Term Care earlier this month, requiring all long-term care homes to conduct active screening for all staff, students, volunteers, visitors, resident admissions, readmissions, and returning residents for symptoms of COVID-19 and their travel history. Active screening requires a screening station to be set up at the main entrance of the facility to ensure all individuals entering are screened before being allowed entry. This screening station should operate during regular business hours and at shift change. Outside of these times, procedures must be in place to screen all people entering the home and that these visits are documented in a logbook. Recently, the Ministry of Health and Long-Term Care issued a memorandum indicating that all long-term care homes are to conduct active screening and only allow essential visitors entry to the facility. Only essential visitors are allowed entry to visit residents who are very ill or residents who require end-of-life care. Active screening is to take place at all long-term care homes until further notice. Most of you will have set up a screening station already. Here are some considerations for your screening station. Make sure you have appropriate staffing to maintain the screening station during regular business hours. It is recommended that signage be posted at the entrance to inform all staff, volunteers, students, residents, and visitors of the active screening process taking place. Your facility should have clear rules at the entrance on who to allow or prohibit entry. At the screening station, it is recommended to have available alcohol-based hand rub with a 70 to 90% alcohol content, facial tissues, procedure masks, a standard script for screening that includes a process for handling visitors or staff who fail the screening. The script will help any staff who may need to suddenly cover the station on exactly what to say. If you have any handouts, have those ready to provide for all visitors. Provide education to visitors on proper hand hygiene and proper use of PPE if resident is on droplet and contact precautions. There are 4 screening questions to ask all visitors. The first question is asking about the symptoms of COVID-19, whether they have fever, new or existing cough, or difficulty breathing. If visitors say yes to any of the symptoms, they are to be asked to leave the facility until their symptoms are resolved. If they say no, there are 3 more questions to ask pertaining to travel and close contact with a COVID-19 case. The second question asks if they have traveled outside of Canada in the last 14 days. The third question asks if they have been in close contact with someone who has been tested positive or awaiting results for COVID-19. The last question asks if they have been in close contact with a person who has acute respiratory illness who has traveled outside Canada in the last 14 days. For the last 3 questions, if any visitor answers yes to any of the questions, they are to be asked to leave and return after 14 days from their exposure. In addition, they should be advised to contact their healthcare provider, Telehealth Ontario, or visit the Windsor-Essex County Health Unit website for further information. Active screening must be conducted for all new resident admissions, readmissions, and returning residents over the phone if possible, and then again at the screening station. The 4 screening questions should be asked. During the screening process, if a resident develops cough, difficulty breathing, or fever, and has either traveled or been exposed to a case of COVID-19 in the past 14 days, the facility should do the following: isolate the resident in their room, instruct the resident to wear a procedure mask if tolerated, initiate droplet and contact precautions when providing direct care for the resident, and lastly, report the suspected or confirmed COVID-19 resident to the health unit. Prompt identification and isolation of a suspected COVID-19 case can significantly reduce the chances of further transmission. If COVID-19 is suspected or diagnosed in a staff member, return to work should be determined in consultation with their healthcare provider and the WECHU. Staff must report to occupational health and safety prior to return to work. Active screening requires the facility to instruct all staff, volunteers, and students to self-monitor for signs and symptoms of COVID-19 and identify any potential exposure risks. If a staff member, volunteer, or student develops any acute respiratory infection, they must not go to work and must report their symptoms to the facility. If staff is required to self-isolate based on recommendations by public health, they must not go to work. Again, long-term care homes are to report all suspected or confirmed COVID-19 cases to the health unit. Self-monitoring and self-isolation are 2 different terminologies used to describe instructions on how a person can prevent the spread of COVID-19. For staff, volunteers, and students who have no symptoms and they may have possible exposure to COVID-19 in the last 14 days, they are to self-monitor for 14 days for COVID-19 symptoms and go about their day, avoiding crowded places and practicing social distancing whenever possible. If staff, volunteers, or students have acute respiratory symptoms, they are not to work and contact their workplace for further information. Report any suspected COVID-19 cases to the health unit as soon as possible. Environmental cleaning. The healthcare environment is frequently contaminated with microorganisms that cause commonly transmitted diseases such as influenza, RSV, C. difficile, rotavirus, and noroviruses. Routine and effective cleaning and disinfection is necessary to protect residents, staff, and visitors from infection. That means we need to have a good understanding of proper cleaning and disinfection practices, especially when residents are under droplet and contact precaution. This includes what products to use and how to use the products. Topics covered in this section are not just specific to COVID-19, but should be applied at long-term care homes routinely and during instances of outbreaks. All surfaces of equipment in a long-term care home must first be cleaned and then disinfected. These include blood pressure cuffs, thermometers, bed rails, bedside tables, slings, walkers, wheelchairs, electronic equipment, etc. If equipment is being shared between residents, cleaning and disinfection must be conducted after each use before it is used for another resident. Cleaning refers to a process that physically removes foreign materials such as dust, debris, and organic materials such as blood and microorganisms from a surface or object using soap, water, and mechanical action. Without proper cleaning, the foreign matter can inactivate a disinfectant, in other words, making the disinfectant less effective against harmful microorganisms. Remember, cleaning does not kill microorganisms. It's best to clean from least contaminated to most contaminated areas. Disinfection is the process used on surfaces to kill most microorganisms, but may not kill all bacterial spores. For more information, refer to Public Health Ontario's guidance document on best practices for environmental cleaning for prevention and control of infections. Now that we understand the basics of cleaning and disinfection, let's talk about how long the SARS-CoV-2 or COVID-19 virus can survive on a surface. In general, certain viruses can survive on surfaces for a certain length of time, and if staff or a resident touches a contaminated surface and then proceeds to touch any mucous membranes, nose, mouth, etc., they may be infected with any viruses that were on that surface. With SARS-CoV-2, the virus that causes COVID-19, it appears to behave like other types of coronaviruses, where they can survive on surfaces for a certain length of time. Studies on other types of coronaviruses and experimental studies on the current virus suggest SARS-CoV-2 may persist for days on a surface depending on the viral load, the type of surface, temperature, and humidity of the environment. The exact time frame is still currently being studied by researchers, but regardless of the time frame, cleaning and disinfection of surfaces is key to stopping the spread of the virus. For cleaning and disinfection frequency, it all depends on the equipment and surface. If any surface or equipment is contaminated with bodily fluids, the surface is to be immediately cleaned and disinfected prior to storage or use. Any equipment that is shared between residents, such as slings, blood pressure monitoring machines, oxygen tanks, etc., must be cleaned after use before it is used for another resident. During any respiratory or enteric outbreak, increased cleaning and disinfection should be conducted on commonly touched surfaces or high-touch surfaces, such as doorknobs, door handles, light switches, toilet handles, handrails, chairs, tables, elevator buttons, telephones, cart handles, and electronics used by staff with an appropriate cleaner and disinfectant. These high-touch surfaces should be cleaned and disinfected at least twice daily, and if they are contaminated with bodily fluids, they are to be immediately cleaned and disinfected. There are no special precautions for laundry and linen items and for dishes and cutlery. Routine practices for these items are sufficient. This means follow your general policies and procedures for cleaning and disinfecting those items. If there are resident or staff who is suspected of COVID-19 or is positive for COVID-19, conduct enhanced cleaning and disinfection for all areas and surfaces in the facility. Keep in mind that items that cannot be cleaned and disinfected should not be used and should be removed from the facility. Consider using products that are ready to use or pre-mixed so that it eliminates having to measure out any solutions. Using a one-step cleaning and disinfection product can ease having to buy separate cleaning and disinfectant products. When selecting a disinfectant, make sure it has a drug identification number or DIN number. This verifies that the product has been authorized by Health Canada for sale. Ensure the disinfectant you have available on site is effective against the infectious agent spreading. The label should have an effectiveness claim indicating general virucidal and bactericidal or broad spectrum disinfectant properties. For COVID-19, review the disinfectant label and determine if the product claims to be effective against human coronaviruses. In order for the disinfectant to be effective, follow the manufacturer's instructions on contact time, meaning how long the surface is to stay wet for, expiration date, product use, and use of personal protective equipment requirements. Most facilities will have the convenient one-step cleaner and disinfectant wipes on hand. Keep in mind when using these disinfectant wipes, make sure the wipes are not dry. If they are dry, please discard the product as the product is no longer effective. If the surface is heavily soiled with bodily fluids, wipes are not recommended. You will need to first clean the surface thoroughly, followed by using an appropriate disinfectant. Preparedness is key for any communicable diseases outbreak. Preventing the spread of COVID-19 requires the same infection prevention and control measures used on a regular basis at long-term care homes. It's recommended to develop or enhance a comprehensive response plan for outbreaks involving emerging and new organisms. In your response plan, consider the following: procedures on how to quickly identify and manage ill residents, how to screen visitors and how to manage staffing numbers, ensuring proper equipment, supplies, and resources are available for routine situations, outbreaks, or pandemics, ensuring policies are in place for staff sick leave, and ensuring proper training and education in infection prevention and control measures are being conducted for staff. The information provided in this presentation is current as of March 25, 2020. As this outbreak evolves, new and emerging information will be provided. Please visit our website for the most up-to-date information. Thank you for taking the time to review this presentation. If you have any questions, please contact the Environmental Health Department at 519-258-2146, extension 4475.